rubber band ligation, to do rubber band ligation. I am not going in detailed procedures because it is not my job. Infrared coagulation, IRC, is again a good instrument for first degree hemorrhoids. It can be used in second degree for relief of for a few years, but the recurrence will be there. I have given the instruments where heat is transmitted for the coagulation of the superior hemorrhoidal artery, so the congestion will be relieved and symptoms will be relieved. Mostly what happens, patient comes for surgery when there is something prolapse is there or since longer duration. So third degree hemorrhoids without external piles, this should be my choice of management. But I don't do every procedures because results are good with ligation and excision. If we do in local anesthesia or short GA, ligation and excision gives long-lasting results. Rubber band can be tried, but chances of recurrence are more. Lesser hemorrhoidopexy I have tried, but in that my experience, it is not painless. It is a costlier instrument. Per patient cost is again high. So I convince the patient, whether you want to give more money, I will do laser hemorrhoidopexy. I have to take the instrument on rent. I have to pay it, I will do it. Otherwise, I will go for ligation and excision. In my experience, almost 99% patients agree with me, they are not ready to use laser hemorrhoidopexy. Stapler hemorrhoidopexy, for that, it is a good when there is no external component, when there is a circular hemorrhoids, when there is simultaneously Gudabrans or prolapse rectum is there. It is a good procedure. It should be done with good expert hands. One should not try because there are severe complications if we are not expert in doing stapler hemorrhoidopexy. And I have seen patients who have died after hemorrhoidopexy. In Europe and Italy, from where the stapler was developed, government has banned to use it unless they have taken the permission to use it for a specific cases. Sclerotherapy is not that much useful, but people try it. So I have written here, infrared coagulation is not that much good for this. Cryosurgery was performed in past before 30 years. Nowadays, mostly it is not being used. Third and fourth degree hemorrhoids with intra-external components. These are the choice of procedures. Hemorrhoidectomy, it may be open, it may be closed, it may be open with harmonic scalpel, but harmonic scalpel have a bloodless field, but complications are high because it gives an inflammatory process in the sphincter. Later on, stricture develops in many patients because while using harmonic scalpel, surgeon cannot notice whether any component of the sphincter is involved, it is damaged or not. So harmonic scalpel is not being used by many surgeons at present. I have seen the cases of complications of harmonic scalpel. I have discussed about stapler hemorrhoidopexy and laser hemorrhoidopexy. In laser hemorrhoidopexy, if there are external component, one has to excise it. Again, you are creating pain, so it is better to do hemorrhoidectomy. So chances of recurrence will be very less. If there is no external component, if you have an available laser instrument and patient wants it, yes, you can go for it. See, these are some types of third or fourth degree hemorrhoids. Ayurvedic references. Atha prayojya dahasya, atha aprayojya dahasya, nirgatan kapavat jan, sastamba kandu ruka shofan abhyaja gudakilakan. When you cannot do any agnikarma or like that, what you can do it? Nirgatan kapavatajan, because there will be no that much bleeding. Now prolapsing is there is no sphincter spasm, sphincter tone is less, so bleeding will practically nil, only prolapse is there, so it may be a kapavata hemorrhoids. Symptoms will be like this. You can use Dhupana, Alepana, Abhyanga, Prasavanti Gudankura. You have to take the blood, congested blood from it. Sanchitam Dushtarudiram Tata Sampadyate Sukhi. The Kasisadi tel mostly used for that at that time. What I understood it. Etad Abhyangato Arsansi Ksharvat Patayat Drutam. So if patient is not ready for any surgery, in that cases, you should ask the patient to apply Kasisadi tel with Arshopidon Yantra. It means anal dilators, so we can squeeze out the blood from the hemorrhoid plexus into the circulation, and Kasisadi tel will give some char effect. So there will be some more fibrosis and patient will have some less prolapse. One should give Swedan, that is a Pindena, Drava Svedena Vapunaha. Pind means we have seen the patients who are using hot bricks to have a fermentation. They sit down on the hot bricks. Or Auga Swed, that is a Drava Svedena. Dhupanam Hitam Arshasam. There are many dhup given by the Acharyas, practically by Charako. I have not tried it. We can use it. We have to try it for conservative line of treatment, for palliative treatment. For Gudaja Varti have advised for this type of Arsha. I have not tried it. We have to do some work on this. Nirgatan Kapavata, some lab are given. When you cannot do Kshar Karma, then use lab. The similar effect will be achieved. What we can apply? Snohi Kshir, Haridra Churana lab, Gomutra, Pipali Churana, Kukkuta Purisha, everything have a caustic effect or some quaternary effect. Gunja, Haridra. These are the most common lepas prescribed in Ayurvedic texts. Modern are using in this type of cases some lep, magnesium sulfate and like that. I have received this case from one my student. Sir, no significant clinical changes was found in this patient after giving 5 days Xenofox OZ tablet with Dolostus, Ceratopeptidase 1BD and daily dressing with magnesium sulfate and glycerin and hot water sits bath. First visit after 1 week. Size is increased, not decreased. You can see there are internal hemorrhoids simultaneously. It is increasing. So, in my experience, this type of local applications don't give a good results. So I don't go for it. I always go for it in 3rd and 4th degree for surgery. In 4th degree, when it is not reducible, I advise the patient go for surgery immediately. We can do it in local anesthesia. There will be very less bleeding. There will be very less bleeding because they are all are thrombosed. Only few skin cut will bleed, otherwise there will be no bleeding. Dissection will be very easy because vessels are thrombosed. Separation will be very easy. So one should try it. Once you will do it surgery in these cases, you will be happy that okay, it is very easy. These are the photographs of some patients operated. We can do it in local anesthesia easily. You can see it. We can keep a good bridge in this type of protruded mass even. Don't worry it. It's a technique. I will explain it. So if you can follow it, you can do it. So they see how much external internal components inflamed, congested. This is the surgical wound after 4 days. So we can do it keeping all bridges in between, nothing difficult. Here again, this is a case, you can see it is just like a tag or fissure, sentinel pile, but it is not fissure. We see there is a fissure at 7 o'clock. No, it is a burst hemorrhoid, external thrombosed pile with internal hemorrhoids. So I have treated with just like a 3rd degree hemorrhoids, and this is the last wound. We can do it surgery even in local anesthesia. But I prefer some different anesthesia. We will discuss it later on. This is a one demonstration of some my surgical steps. A video of photographs. It is not a true video. It is a video of photographs. How we can do it? see, this is a left lateral hemorrhoid. I have dissected with scissor. I am transfixing with Lenon 20. These are many thrombosis there. It is transfixed now. This is a 7 o'clock hemorrhoid. I am doing it. I separate the sphincters with blunt dissection. This is 11 o'clock hemorrhoid. Separating the sphincters with scissors and blunt dissection. And after ligation, I excise all the pile masses. So this was the small video. Now, what should we keep in mind? I prefer don't give V-shape incision. I say don't. See, in lateral picture, book picture, there is a V-shape incision. If you go through the V-shape incision, you are creating a larger wound at the dentate line. You are creating, I am pointing my cursor, you are creating a larger wound at the dentate line. So if you remove all three hemorrhoids, there will be a very less breach. So try to make a half dumbbell shape. I have given this picture dumbbell. This is not a typical drawing. So give half dumbbell. If you make it a half dumbbell from here, then your incision should be up to the dentate line like this, half dumbbell. So the inner portion at the dentate line will be a small incision. So there will be a good mucocutaneous breach at the dentate line. So chances of anal stricture will be practically zero. If you make incision like this, that is a half dumbbell shape incision. Always do blunt separation of the internal sphincter. Don't go sharp dissection. As soon as you make the cut on the skin up to the external subcutaneous part of the sphincter, separate the subcutaneous part of the sphincter with gauze piece, then separate the internal sphincter, keeping one finger in the anal canal. You can easily separate the internal sphincter and then transfix it. So there will be no sphincter damage at all. There will be very less pain. There will be no stricture postoperatively. After, don't put any packing inside. Don't put any packing. You put liquid paraffin goes tucked in the wound area. So during follow-up dressing, it will not do bridging there. Say. If you don't put liquid paraffin goes there, then chances of bridging will be there. When patient will pass the stool, there will be some bleeding. If you put this, there will be chances of bleeding will be practically zero. Give T-bandage always give proper T-bandage, because proper anal support cannot be achieved with any dressings, any sticking plaster or anything. So if you have given a proper support at the perianal space, there will be less edema, so there will be a less pain, there will be early recovery, there will be no edema, means there will be chances of bleeding again. So always give T-bandage properly. Remove the bandage very next day if patient wants to defecate, or you may extend it to up to 48 hours. So these are my specific protocols for amerectomy. Other points will be discussed later on. So these are the pictures all I have operated with surgical excision, amerectomy. We can do it without any difficulty. These are not hemorrhoids. Don't do surgery according to hemorrhoid. These are not hemorrhoids. First is a practically varicocele of the hemorrhoidal plexus, everything simultaneously, or vascular angiopathies. We can say it is a angiopathies, like this is, and this is a prolapse rectum, but not hemorrhoids, so don't treat as hemorrhoids. These are some references of Doppler guided hemorrhoidal artery ligations, which are highlighted by different colors. You can see recurrence is almost 12% in Doppler guided hemorrhoidal artery ligations. When you are sitting in a town place or in a small places, if there are recurrence after 10 years, many people will not come to you for management through the surgery. So one has to select the line of treatment which gives a long-lasting result. So I prefer amerectomy rather than the Doppler guided hemorrhoidal arterial ligation. These are the findings of the staple hemorrhodopexy. Staple hematopaxy, what I said, if the complications are there, it has always a severe complications, severe bleeding, severe sepsis, long-lasting pain, or incontinence or recurrent fissures or death can take place. These are the articles. Laser hematoplasty. It is useful, I think, for second and third degree for a longer duration where there is no external component. But instrument cost is high. If you have a rented machine that we can use it will easily. There is no practically technical benefit in using in external hemorrhoids. You have to make the wound by laser or by cautery or by scissor or by knife, anything. There will be a similar pain, anything you use it. So it is not worth where external components are there. But there are some chances of thermal damage to internal sphincters. We don't know the long-term results which can create, because when we are introducing the probe inside the hemorrhoidal plexus and transfer the heat, so it is a controlled heat. We have to put the ice pack immediately because so much heat is there. I have seen it, palpated it. If we can put the ice on the mucosa, but we cannot put the ice on the sphincter. So sphincter damage may be there. Later on, there will be a stricture, we can say it. These are some results of hemorrhoidoplasty by different procedures. Some has used hemorrhoidoplasty with laser, with rubber band, simple hemorrhoidoplasty, or DGHL, or finger-guided hemorrhoidal artery ligation. When they do it with finger hemorrhoidal artery ligation, then there are good results. Otherwise, results are around 90%. Again, 90% are results for few years, not for a longer duration. So, if you are going to do two procedures simultaneously and taking more charges, then you can have a good results for some good time. So this is the short and long-term outcomes of laser hemorrhoidoplasty for grade 2 and 3 hemorrhoidal disease, not grade 4. So follow-up is, these are the last article what I have, I can find it on net. It is a 5.4 years, no longer duration. Conclusion is that although laser hemorrhoidoplasty achieves a high short-term success rate with respect to stage reduction, so from third degree to second degree to first degree, and symptom improvement, it is associated with a high rate of minor postoperative complications and long-term recurrence. Therefore, laser hemorrhoidoplasty should be used with caution. This article was published in Colorectal Diseases in 2019. See, now we will discuss some other hemorrhoids, piles, external piles. Out of that, first is external thrombosed pile. First picture, if I remove the thrombosed pile, it will look like fissure. So always, while examining, always consider whether fissure is a true fissure or it is a hemorrhoidal fissure. This patient will give history of bleeding, tag, and pain. Again, but there will be no spasm. Second picture is an infected fissure with a fistula development. Third is a clinically 100% external thrombosed pile at 7 o'clock position. So, line of treatment may be differ each and every cases. So, all thrombosed pile should not be treated in same way. Yes, in third picture, if you take out the hematoma, and in first picture, you take out the hematoma, there will be a pain relief, there will be a reduction in the swelling size, but there will be a tag for permanently. So, I prefer excision of this whole external component from the base, so there will be a no tag formation later on in local anesthesia. See, this is the same patient. Patient looks like an external thrombosed pile. As soon as you ask the patient to strain it and you retract the anal verge, you will see another hemorrhoid simultaneously, external thrombospile simultaneously. So in this case is do proctoscopy, there will be some internal hemorrhoid simultaneously. So go accordingly, which findings you suggest. This is the Ayurvedic reference for thrombospile. Avartmanam utsunam kathinebhyo haret ashru. Which are the swelling you can see externally, which is utsuna, which is hard. Haret ashruka, remove the blood. How? Jalaja jaloka, shastra karma, suchi यानी प्रच्छन्न कर्म, kurch यानी प्रच्छन्न कर्म, punah punah. You have to do it repeatedly, otherwise there will be again hematoma. If you don't exercise it. What is interesting, in this sloka, Charak says, Avartmanam rudiram raktarshobhya pravahayat. But this slok is given in the treatment of Suskar Chikitsa. While describing all Suskar Chikitsa, Susrut Charak gives this reference. So he want to say, patient will be clinically Suskars. Basically, it is a case of Raktars. Suskars, it may be a painful, it may be hard, everything. So it is a Suskars and Vatajars. In Vatajars treatment, but technically it is a Raktars. So you have to drain it. Jaloka bihi tatha shastraihi. So it is better to remove the clot, to excise the skin tag. See, here is a case of large hematoma which we cannot see outside at the anal verge because this was not coming outside. This is under anesthesia photographs. Large hematoma at the 11 o'clock position. I have excised this up to the dentate line. So subcutaneous part of the external sphincter is visible in middle picture. So if we excise it, it will be very good. It is an easy procedure. There will be very less bleeding. Again, this is a case of thrombospile. It is not a case of fissure tag or infant fissure. As soon as you pass the proctoscope inside, you can see it is a thrombospile. Now we will discuss again third clinical entity which I consider as a URS, that is a fissure. When there is an acute fissure, it is a adrushya URS. Acute fissure usually heal promptly. If you do proper management, it will heal with conservative line of treatment properly. So during the discussion of conservative management, I told that fissure can be treated with conservative line of Ayurvedic treatment. Chronic fissures considerably wreck to heal. Chronic fissure will not heal. Why? At the lower end, there is a sentinel pile. At the upper end, proximal end, there may be an anal papilla. So now, fissure is converted into the URS. It may be drushya, we can see it by proctoscopy. Or, this acute fissure may convert at any stage into abscess formation. It may convert into perianal abscess or intersphincteric abscess. Later on, it converts into the fissure fistula. If you go through the literature, you will find that in Arsha Purvarupa, Yana Malotsargat, Susrut has written like that, there will be a pain at the anal region. So, if you can't see any swelling, doesn't mean there is no abscess in the fissure. There is no abscess. If there is a severe pain is more than hours, persist, gradually increasing, then always think about the simultaneously existing abscess. So I consider as a URS, so I treat according to URS. So when there is a sentinel pile and papilla, I always excise it under local or short GA with local anesthesia. And I have achieved a good results. No need to do the lateral sphincterotomy. Polyp is a type of URS. So it should be excised. This is a case of juvenile polyp. Patient should be told that in the adulthood age, if patient develops bleeding or something, diarrhea or increased frequency, so go for colonoscopy, or at your young age, after teenagers, once go for the colonoscopy to rule out the other polyps in the colon. If there are no polyps in the colon, then chances of converting into the carcinoma will be practically zero. If there is polyps in the colon, one has to go for repeated colonoscopy for prevention of the carcinoma of the colon. This is a condyloma acuminata. Again, it is a URSA because it is on the Guda region. So my choice of treatment is Agni Karma with treatment of the cause because it is a secondary. Weekend is a quasi-secondary. Primary may be syphilis, primary may be viral. So one should treat accordingly. So if it is a syphilis, that it will be a condyloma lata. If it is a plain viral, it will be a condyloma acuminata. So this is a second case of condyloma acuminata, enlarged hypertrophied. This is a done Agni Karma or cautery. This all cases done with gynec cautery. Don't use the electrocautery. There will be no deep burns with the gynec cautery. Papilla, we can consider because there are Mansankur papilla as a URS. We have to take it out. It is an easy procedure. You clamp it with artery forceps. You cut it, do cauterization at the base. There will be no recurrence. These are the congenital papillas. See, here I am giving one example. Here it is a prolapse strangulated papilla which has created thrombosis of the external components and edema. Edema is due to the lymphatic obstruction, due to the spasm. So, better to reduce it immediately on local anesthesia or short GA or with xylocaine jelly, whatever you can do it, and later on remove the papilla. So again, there will be no prolapse, there will be no external thrombosis. This is a case of villous adenoma. Again, it is a URSH growth, what I say. I have removed it with, but I use always a Char Sutra in adenomas. I transfix the adenomas from the submucosa, not from the pedicle, neck, but from the healthy areas and then sent for biopsy. Your stock should be having no malignancy. Though growth is having malignancy, it will not recur. If your stock or pedicle is having malignancy, then refer it immediately. There may be chances of spreading elsewhere. Carcinoma of the rectum must be ruled out as the primary cause of the internal hemorrhoids in older patients. What I want to convey is, when patient has a hemorrhoid, internal hemorrhoid, complaints after the age of 50, don't consider as a primary internal hemorrhoids. If there is no history of bleeding, swelling, etc. before 50 years, always look for the carcinoma of the rectum, sigmoid colon or colon. If you rule out it, then go for treatment of the hemorrhoids. It may be due to the straining of the prostate. Otherwise, you will be in trouble. This is again case of the CNS which looks like hemorrhoid, but it is a cytochemically dysplasia. It is an early polypoid hyperplasia which converts into the malignancy. So don't treat as a hemorrhoid. Again, it looks like URSH or Mansankur. According to Ayurveda, it is a URSH, but it is a melanoma. You can see internal hemorrhoids in this case. Don't touch it. It is a highly growing tumor. Patient has a swelling of 2 months only. So now we will discuss of the protocol, some points. What to do? Educate the patient. Always educate the patient regarding the hemorrhoids. Which type of hemorrhoids are there? How many hemorrhoids are there? Which type of procedure is better for you? What will be the end results? What will be the long-lasting result? And what will be the cost? Convince the patient, explain everything. Patient will be ready, whatever procedures you want to do it. Otherwise, most of the people would say, go for the laser, go for stapler. It will be a painless surgery because we want to earn more. We don't teach the patient. We don't educate the patient. So always educate the patient. Take always written consent. What you have educated the patient, write down everything. Explain the procedure, explain the anesthesia, explain the outcome, everything in written, and take the consent. Always go for pre-operative investigations. We will discuss it. When not to operate, we will discuss it. Bowel preparation, laxative, we will discuss it. Local part preparation, shaving. Yes, in hemorrhoids, if it is too much hairy, do shaving just 1 or 2 fingers around the anal verge. Don't go for a large shaving area because it is a painful after a few days. Choice of anesthesia. We will discuss it. Selection of procedure, we have discussed it. Use of antibiotics, we will discuss it. Post-operative management, we are discussing later on. I have discussed education of the patients, everything. Pre-operative investigations, go for these investigations. I don't do PT in every case. If patient is alcoholic, I do prothrombin time in each and alcoholic patient. If prothrombin time is high, always go for the abdominal sonography. If there are some changes in the liver, always go for the find out of the esophageal varices. Otherwise, you will be in trouble. After hemorrhectomy, in few months there will be hematemesis, and you have missed one diagnosis. It may be if prothrombin time is high, there will be a later secondary or reactionary bleeding will be there. Always do urine routine microscopic examination to rule out the urinary tract infection. Otherwise, there will be chances of retention or straining of the. Always go for SGPT, because I have found it that when there are viral infection months are there, chances of liver inflammation is there. So at that time, there is a precipitation of hemorrhoidal symptoms in the patients. So SGPT high, go for some treatment, wait for a few weeks. When everything is normal, if you will operate it, there will be less complications, there will be less pain during defecation, there will be a good appetite, everything will be less. HBsAg for prevention to spread infection to surgeon or staff or to other patients, it should be done, and after due precautions, we can do it surgery. Always go for HIV where it is a highly thick population area is there. I don't do HIV in each and every patients. I find out the cases because I have seen that out of 100 HIV patients, I have not seen even a single case of HIV positive. So I have stopped it doing HIV in each and every cases. If there is a blood transfusion history, if there is a surgical past history, if patient is coming from lower socioeconomic or patient of higher socioeconomic group having many friends, many parties or many tourism, then I go for HIV. Always do serum creatinine, because if patient is having any renal diseases, healing will be delayed. You cannot give analgesics which are nephrotoxics. You cannot give antibiotics which are nephrotoxics. So we should know serum creatinine level. X-ray chest, if you can find that there is a simultaneous tuberculosis or anything lesion, go for X-ray chest. And ECG in each and every cases of hypertension or old age patients. When not to operate, when there is a severe anemia, don't operate it immediately. Because I have not seen, I have heard from some few friends or some students, they have operated in severe anemia and patient died. Don't operate after immediate BT is given, not a single BT. If single BT, it's okay. But in old age, if you have given more than one BT, don't operate immediately, wait for 1 week, let the cardio circulation establish properly, then go for surgery. Otherwise, I have seen I have heard about the 2 cases by those who are practicing since years together. After BT, very second day they operated and patient expired.